No?
Week 3, 4, and 5.
Sorry, I can't hear you very well.
The exam
Uh-huh.
is on week 3, 4, and 5.
It's on week 4 and 5.
4 and 5. Okay.
Yeah, because week 3 was on the exam 1. Yep. So weeks 4 and 5 for exam 2. Okay. And remember, since we're doing Kahoot for class, you guys all need to be on here, please. So I should have 18 of you guys on the Kahoot. Looks like we're waiting for 2 more. Okay, 1 more. Who's still getting on? Okay, perfect. Thank you. All right, so we're in week 5, which is neurological and musculoskeletal, okay? Okay, the nurse explains that Brian's traction is reserved for children who weigh less than blank pounds. 10 pounds, 20 pounds, 30 pounds, 15 pounds. £30. Good. And Brian's traction is like with pulleys, kind of like Buck's traction, but it's a little bit different. Okay. Instead of coming up and over the bed, it's kind of above the bed, essentially. Okay, multi-select. What nursing interventions are important for a patient with hydrocephalus before surgery? To turn frequently to prevent skin breakdown, keep head of bed flat, encourage activities and stimulation, monitor vital signs and neurological status. Yes, turn frequently to prevent skin breakdown and monitor their vitals and their neurological status. Good. What about after surgery? Probably similar things, right? And you might have an order to keep the head of bed at a minimum degrees as well. Do we all know what hydrocephalus is?
Fluid on the brain.
Mm-hmm. Yep. Yep. What about how do they fix it?
Like putting in a shunt.
Yep. Good. Okay. What intervention will the nurse caring for a child in Buck's skin traction implement? Assist the child to be pulled up in bed, keep the child's heel on the bed surface, maintain the child's feet against the foot of the bed, or position in high Fowler's position. Yes, they'll need your assistance to be pulled up in bed because you're going to need to be helping with the weight of the traction, like holding the weight so that way it's not pulling and counteracting their fracture. Buck's traction a lot of times is used with femur fractures in kids. That's probably the most common usage. Okay, what pain management would be most appropriate for a child who is status post femur fracture repair? Ibuprofen, tramadol, or opiates? Opiates, okay? Femur fractures are very, very, very painful. A lot of times they have muscular spasms as well. So they might also be on a muscle relaxer. That's kind of the hope that Buck's traction helps to reduce the muscle spasms by keeping that fracture in appropriate alignment as it heals. But yes, definitely these kids will be kids that get opiates in the hospital. Doesn't necessarily mean that they'll be discharged with those, but they will definitely be getting opiates in the hospital. After a surgery, ibuprofen, some surgeons have some mixed feelings on that. Now, tramadol is kind of in that same category as an NSAID, just kind of a step up NSAID. So, because of the risk of bleeding potentially. So sometimes those aren't utilized depending on your surgeon. Okay. Okay, what will the nurse include when caring for a child in Buck's extension? Releasing the weights on a schedule, positioning the child with hips flexed at 90 degrees at all times, keeping the weights in contact with the floor, checking for skin irritation around the traction equipment. Yes, you're going to be checking that skin around the areas that the traction is attached to that kiddo. Okay. You don't want the weights on the floor because they're not doing anything at that point. Okay. And you also don't want to release the weights on a schedule because, once again, not helpful in keeping that aligned. Okay, what is included in the definition of pain according to the Academy of Pediatrics? Pain can be measured accurately. Pain is actually less than what they say. Pain is whatever the client says it is, wherever the client says it is. And then pain is due to the release of the epinephrine. Yes, pain is whatever the client says it is. And wherever they tell you it is, you can't, confirm or deny that they have pain and how extreme it is. Okay, what statement by the mother indicates understanding on how to administer oral antibiotics for otitis media? I will share the medicines between siblings if their symptoms are the same. I will continue using the medication until the symptoms are relieved. I'll give the medication with a glass of milk. I will administer the prescribed doses until it's all used. Yes, good. Administer until it's all gone. You don't usually give antibiotics with a glass of milk. Sometimes that's harder on their stomach. They should eat a little something usually with antibiotics, but dairy is usually not something that I recommend that they eat. And then obviously don't share antibiotics with siblings, because then the kiddo who actually has the ear infection, which is otitis media, okay, won't actually get the appropriate treatment. Good. Okay, another multi-select. What is the best way for the nurse to communicate with a 10-year-old child who has a hearing impairment? Remain face-to-face with the child, establish eye contact, remain at eye level with the child, talk in short sentences. Yes, all of those things can be helpful in a kiddo that has a hearing impairment. Because kids with hearing impairments, they're going to learn to read lips. So you want to be able to, stay to where they can read your lips. And if you're talking in really super long sentences, it's harder for them to keep track with what you're saying. Okay. Good. Okay. What is the best way for the nurse to communicate with a child age 10 who has a hearing impairment? I feel like we just did this. Let the child's parents communicate for her, face the child and speak clearly in short sentences. The child's ability to communicate will be on a 6-year-old's level. Use gestures and signs as much as possible. Yes, face the child and speak slowly and clearly in short sentences. Good. Okay. The nurse is reviewing the characteristics of Ewing sarcoma. Which statement indicates understanding of this disease? Metastasis is rare. The disease is sensitive to radiation and chemotherapy. Amputation is the accepted treatment. The disease is more prevalent among toddlers and preschoolers. Okay, so the disease is not more prevalent in toddlers and preschoolers. It's actually usually more adolescent age kiddos, school age adolescents. And then this is a cancer. Okay, it's a bone tumor. It's usually in the femur. And so it's sensitive to radiation and chemotherapy. Now, I will say that sometimes if radiation and chemotherapy isn't helpful, then they will amputate. Okay. And usually when they do that amputation, they cut out the femur and then they reattach like from below the knee. So the tibia and fibula up in this place of the femur where it's at. So that way that kiddo still has a stump to be able to have a prosthesis. Okay. And you'll see that on the PowerPoint. Okay, what characteristic manifestation does the nurse caring for a child with Duchenne's muscular dystrophy document? Falls frequently and is clumsy, has delayed fine motor development, ambulates by holding onto furniture, exhibits atrophy of the calf muscles. Okay, so falls frequently and is clumsy. Okay, that's the most classic manifestation. Okay. Doesn't mean that they're not going to have motor delays, because they likely will. Okay. Good. Okay, the nurse is providing instructions about how to treat a sprained ankle. A statement that needs additional teaching is keep the leg elevated when sitting, wrap the ankles in an ACE bandage for support, apply warm compresses to the ankles for the first 24 hours, put an ice pack on the ankles, alternating 30 minutes on, 30 minutes off. Warm compress. Why warm compress needs more clarification.
Because you're supposed to treat with ice first. Is that true?
Yes. Yeah, initially.
Yeah.
Will it cause it to be more inflamed or something?
Yes, more swollen, right? Because the blood's gonna, kind of pool more there versus with ice, it constricts. Okay. Good. Okay, how is pain managed the most effective way? Always administer the highest dose of opiates ordered. Always administer low dose analgesics on time and around the clock. Give maximum doses of acetaminophen and opiates only as needed. Yes, low dose analgesics on time around the clock. So now, obviously, if your kid's having a 10 out of 10 pain, then you're probably also going to need to give them something a little bit stronger than, Tylenol or ibuprofen, depending on their diagnoses. Okay. But the best way to stay on top of it and to manage pain is to stay on top of it. Okay. Okay, how does Russell traction provide adequate skin traction? Supplies continuous pull in 2 directions, subluxes the tibia, prevents the knees from flexing, or it does not interfere with range of motion. Yes, good. It's pulling in 2 different directions. Usually, up a little bit on the knee or on the leg, and then down towards where the weights are. Okay. Okay. What finding would the nurse assess would be assessing the neurovascular status of a child in Russell's traction report immediately? Ability to wiggle toes, skin that's warm to touch, capillary refill less than 3 seconds, or bluish coloration of the skin. Yes, good. Bluish coloration of the skin. With fractures, you want to have the 5 Ps. So their pain needs to be managed. They need to be able to feel, like, have sensation, okay? Wiggle, pink, have good pulses, okay? Not be pale, not have discoloration. If any of those things are missing, then you're worried about circulation in that foot or in that extremity that's fractured, okay? Okay, what intervention is appropriate for a nurse assessing a pre-adolescent child for scoliosis? Look at the child's shoulders and hips while fully clothed. Observe their gait while they're walking forward, heel to toe. Have the child flex the knees to look for uneven knee height. Bend forward at the waist and observe the child's back for asymmetry. Yes, have them bend forward at the waist, so feet together, bend over like they're going to touch their toes. If they can't touch their toes, that's fine. Just let their arms dangle, but keep their legs straight. And then you're going to look at their back for asymmetry. School nurses used to do that a lot. I don't think that they're doing that quite as often, but kids, when they get their physicals done for sports or for their well childs, that should be being done pretty routinely. Okay, what nursing action will significantly decrease the risk of serious complications for a child in Bryant's traction? Bandages are wrapped tightly, neurovascular checks are done frequently, the child's buttocks is resting on the bed, the child is restrained from rolling over. Yes, neurovascular checks. Okay, that's going to be the biggest thing with kids who have fractures and who are in traction. You're going to be checking those neurovascular checks. Okay. Good. Okay, which intervention would be helpful in relieving morning discomfort associated with juvenile rheumatoid arthritis? Taking a warm bath in the evening, wearing splints at night to prevent extension contractures, applying moist heat packs upon awakening, sleeping with 2 pillows under their head. Okay, so juvenile rheumatoid arthritis, this is going to be heat in the morning. Okay, that's going to be the most beneficial thing for them because their pain is usually the worst when they're getting up and trying to get out of bed. Okay. And it's heat to promote, good circulation to those areas. So the discomfort improves from that piece. Okay, what instruction would the nurse provide to an adolescent who has been fitted with a Milwaukee brace? Remove the brace before sleeping, wear the brace over regular clothing, wear the brace directly against your skin, or wear the brace over a t-shirt for 24 hours or 23 hours a day. Yes, okay, so they're gonna wear the brace over a t-shirt, okay, for 23 hours a day. Okay, good. Which observation makes the nurse consider the possibility of child abuse when a mother says her young child fell? Red, green, and yellow bruising on the body, a broken arm last year, and the child's being described as accident prone. Bruises are dispersed on the head, arms, and legs. The mother is very anxious for her son to get medical attention. So different stages of bruising. So red, green, yellow bruising throughout his body. So that's kind of a sign. Now, normal kids will get red, green, yellow bruising on their shins and things like that. And that can be normal childhood bruising. But if it's throughout the body, that's a little bit more concerning. There's different stages of bruising. Okay. Good. Okay, on entering the room of a child in Buck's traction, which observation requires a nursing intervention? The head of bed is 20 degrees elevated. The child's heels are placed firmly against the foot of the bed. Ropes are on pulleys. The weights are hanging freely. Child's heels placed firmly against the foot of the bed. So if that's happening, they're not in the right alignment for traction. Okay. So their heel has to be kind of elevated. And not right up against the foot of the bed. Okay, what type of fracture would most likely alert the nurse to the possibility of physical abuse? Spiral fracture, a stress fracture, compound fracture, or green stick fracture? Okay, spiral fracture. Okay. So that spiral fractures require a twist kind of injury. Okay. So it's usually more indicative of abuse. Okay. Okay, I see your guys' message about Jackie. I'll hope that she can get back on. Okay. Multi-select. What factors may trigger abuse in a parent? And it's select all that apply. Substance abuse, overwhelming responsibility, high self-esteem, knowledge deficit relative to childcare, being abused themselves as a child, or financial issues, which is going to put more risk of that kiddo being abused potentially. Yes, substance abuse in that parent, overwhelming responsibility, like maybe having to work multiple jobs and just really stressed out, not having a lot of support, being abused themselves as a child is an increased risk factor for child abuse, or for abusing their own child. And then financial struggles. Okay. Okay, what assessment made by the school nurse would lead to the suspicion of strabismus? Child complains of a headache. Child covers one eye to read the chalkboard. Copious tears while watching TV. Red and sclera in one eye. Okay, yeah, so they're covering one eye to read chalkboard. Strabismus is another fancy term for like a lazy eye, okay? So like a wandering eye. So to be able to focus, you'll see sometimes that child will cover their good eye to get their other eye to work correctly. And that's a part of treating strabismus as well, is covering, patching the good eye to make that lazy eye, those muscles work harder. Okay.
Ms. Becker, can you hear me?
Yes, I can hear you.
Okay,
I just
I don't know.
see you for some reason.
And I keep clicking my video, but it won't. I don't know what is happening.
Have you try logging out of Zoom and logging back in and see if that works for you?
Okay.
Okay. What might the nurse explain as a common treatment for amblyopia? Using glasses that will slightly blur the image for the good eye. Patching the good eye to force the brain to use the affected eye. Patching the affected eye to allow the refractory muscles to rest, or using corticosteroids to treat the inflammation of the optic nerve. Patching the good eye. So amblyopia is similar to strabismus. It's just a different direction of the drift. Okay, so they're going to treat it the same way. They're going to patch the good eye and force the brain to use that eye that struggles. Okay. What assessment does the school nurse recognize as a cardinal sign for hyphema? Opacity of the lens, inflamed mucous membranes of the eyelid, a dark red spot in front of the iris, and white yellow reflex of the pupil. So a dark spot in the front of the iris. So essentially it's an accumulation of blood kind of right under the lens of the iris. Okay, it's between the cornea and the iris layer. Usually from something traumatic. Okay, what type of fracture is an incomplete fracture where one side of the bone is bent and the other is broken? Compound, simple, oblique, or green stick fractures? Green stick, okay? So one side is bent and then the other side is totally broken. And that's a green stick fracture. And on the PowerPoint, there's good pictures of and in your book also, good pictures of the different fractures. What does the nurse explain to the parents of a child with febrile seizures? They occur when the body temperature exceeds 100.4. They occur when the temperature rises quickly. They can be prevented by anticonvulsant medication. They usually lead to the development of epilepsy. Okay, so they occur when the temperature rises quickly. Okay, so that's where you see the febrile seizures. Just because kids had one febrile seizures, they're not guaranteed to have epilepsy or a seizure disorder when they get older. Okay, about 25% of kids who have febrile seizures, though, will continue to have seizures, especially when they
Is
have.
that like? Sorry. Is that like even if it's low grade, like even if it only rises to 0.4, but
So, no, I mean, usually it's like rising from normal to like 101 quickly. Or like their normal 98.6 to over 100.4. So no, that's not a febrile seizure. You typically don't see that if they have a low grade fever, like 100.3 or something.
okay.
Yeah.
Okay.
Yep. So it's usually they're having that above the 100.4 threshold of actual fever. Okay. So with kids who have febrile seizures or who have had febrile seizures, it'd be important to tell parents to what? What should they do if their kiddo's sick with a fever?
Give them Tylenol.
Yeah, Tylenol or ibuprofen, depending on their age. Yep. Because if they just let it go and it increases really quickly, like again, then they're more likely to have another febrile seizure. Okay. And some kids just have one febrile seizure with a febrile illness, and then they never have a febrile seizure again, even if they continue to get fevers. But it's just important to let parents know that they should treat them. Okay. Okay. What type of fracture is associated with child abuse? Spiral, compound, green stick, oblique fracture. spiral fracture, okay? Remember, that's the twisting. And you really get concerned about spiral fractures in like kids who are not mobile, really. That's really concerning for child abuse, okay? Kids as they're running and jumping and being really active. I mean, spiral fractures are somewhat uncommon, but they can happen. But if you see that in a kiddo who's not ambulatory, you get really concerned. Especially if the story changes or the child's telling you a different story than the parents, that type situation. Okay, another multi-select. What factors may trigger a parent to abuse their children? Financial difficulties, drug abuse, parents abused as children, or unemployment. Yes, all of those things, okay? Good. Okay, child experiences episodes where he appears to be staring into space. What's the type of seizure? Complex partial seizure, akinetic seizure, absent seizure, or myoclonic seizures. Absent seizures, okay? So if they're just staring off into space, they're absent seizures. These seizures are harder for people to identify, I think, because especially teachers, because I think, you know, kids are just staring off and not paying attention. But if parents are also noticing that at home, it would be important that they see a neurologist to make sure that they're not having some absent seizures and in need of like an anticonvulsant kind of medication. Okay. Good. What is an appropriate nursing action when the child is experiencing a generalized tonic-clonic seizure? Assist the child to bed and then go for help. Stick a padded tongue blade between the child's teeth. Move objects out of the child's immediate area, or manually restrain the child. Okay, move objects out of the child's immediate area. Good. Okay, the legs of the child with CP cross involuntarily and exhibits jerky movements with his arms. What's the type of cerebral palsy? Spastic, arthrosis, or arthrolysis, mixed, tonic-clonic. Spastic. Yep, good. So there's no form of tonic-clonic CP. That's with seizures, okay? So spastic movements. Okay, which assessment finding in a child with meningitis should be reported immediately? A slight drop in blood pressure, tachycardia, elevated temperature, or irregular respirations. A slight drop in blood pressure. Okay. Good. Meningitis is inflammation of the meninges in the brain. Okay. Usually from bacterial or viral infections.
Can you please explain why and how slight it has to be?
Well, so a slight drop in blood pressure, that's because the kiddos, they're progressing further into sepsis, right? So kids will compensate with their blood pressure by, having a normal or slightly elevated blood pressure for a period of time. The thing that you get most concerned about with meningitis is them progressing to sepsis. So the meningitis, the infection, not only in the meninges of the brain, but then spreading to the spinal cord and the blood. So if their blood pressure was normal for a period of time or a little bit elevated and it starts dropping from their baseline, then that's when you'd get concerned that kiddo is no longer compensating their shock. Does that make sense? There's not like a certain number of drop that you have to watch for. You just, your patient's baseline blood pressures. And if they start dropping, it's not just like one drop. It would consistently start declining. If it is doing that, then that's when you get concerned about them progressing to sepsis. Okay. Did that answer your question? Okay. Okay, which nursing assessment suggests the child has a concussion after the child fell and hit his head on the ground? Complaining of a stiff neck, pupils react sluggishly to light, cannot remember what happened to him, sleepy but easily arousable. Cannot remember what happened to them. So pupillary reaction shouldn't really change with concussion. Okay. So not being able to remember what happened is more common with concussion. Okay. A 6-month-old child gets inoculated with H flu, which is Haemophilus influenza type B vaccine. What type of immunization does this protect against? What does this immunization protect against? Encephalitis, influenza, bacterial meningitis, or otitis media? A form of influenza. Okay, so Haemophilus influenza type B is a form of influenza. It's not like your classic influenza that you think of like each year. We have to get our flu vaccine. This is a different form of an influenza virus. So it commonly used to cause bacterial meningitis or a form of meningitis in kids prior to kids getting this vaccine when they were infants. So that's why this one's important. So Haemophilus influenza type B, or HIB, you might see it, HIB. You might see that abbreviation. Okay. But it's not like common every year circulating influenza. Different strains. Okay. Signs of increased intracranial pressure in a 3-year-old include headache and lethargy, high-pitched cry, bulging fontanelles, apnea or crossed eyes, painful head movements, and anorexia. Headache and lethargy. So those are going to be your first signs of increased intracranial pressure with 3-year-olds. Not fontanelles, because fontanelles should all be closed by age 3, okay? Those usually close by like 18 months at the very latest. Okay? If fontanelles are still open at age 3, you're really concerned about something going on. Okay, the priority nursing intervention when administering Dilantin or phenytoin to a patient diagnosed with epilepsy is recording blood pressure, providing detailed oral hygiene, encouraging bed rest, or administering the drug with milk. Yes, so Dilan, you're going to want to make sure you're doing really good oral hygiene on these kids. Okay. You don't give it with milk because that affects the absorption of it. So it won't absorb as well. And you don't have to worry about their blood pressure dropping too much. So it's not when you have to check a blood pressure before. Okay. So oral hygiene. Okay, a practice that has been helpful in preventing intellectual disability is administering Sanford Binet test, a blood test at birth, careful preschool developmental screening, or a urine test at 6 months. A blood test at birth. Why is that? Why do you think it's blood test?
I feel like preventing is a iffy word. It's like detecting maybe.
Yeah, like if
Like
detecting before they're severely delayed.
So what can we detect by blood test at birth?
So they do newborn screening. So there's various newborn metabolic issues that are screened. So things like congenital hypothyroidism, cystic fibrosis, some different genetic kind of conditions that may go along with an increased risk of intellectual disabilities. So by detecting early, you can get those kiddos into those services. Or like say, for example, the kiddo with congenital hypothyroidism, they're not going, along for a few months before we know that they have low thyroid hormone that's affecting their growth and development. So we're able to, start them on thyroid supplementation and all of that earlier on. And it does depend on the state that you're in on what all they test for. But across the board, there are recommended metabolic screenings that are done at birth. That's that like 24-hour after birth blood test that they do on a heel poke. That's what they're looking at. Okay. Which type of seizure presents with jerking movements upon wakening followed by collapsing? General seizure, absent seizure, simple partial seizure, or atonic seizure? Atonic seizures. So those are the drop seizures. So they might get stiff for a second or have a jerking movement for a second, and then they just drop and continue to seize on the floor. But kids with atonic seizures, a lot of times they're not having, the tonic clonic. So they're not going to be really tight. They're just going to drop and kind of maybe, shake. Or just drop and be totally out of it for a little bit. Okay, a sudden cry followed by jerking and then relaxation is typical of what type of seizure? General seizure, absent seizure, simple partial seizures, or atonic seizures? General seizures. Okay, so when you think of general seizures, that's usually the seizure that most everyone thinks of, the tonic and clonic. Like, so tight and then relax, tight, relax, tight, relax. Okay. Good. All right, the seizure is classified by a blank stare followed by rapid blinking or chewing movement where awareness returns quickly. General seizure, absent seizure, simple partial seizure, or atonic seizure. Absent, okay? They don't always have a blinking or chewing movement, but usually, you know, they're staring off for a period of time and then they kind of come back to, and their awareness returns really quickly. Now, with tonic-clonic seizures, those kids will be post-ictal, so they'll kind of be out of it for a period of time after. Okay? So their awareness will not return as quickly. Okay, jerking of one arm progressing into generalized jerking where the patient remains aware is which type of seizure? A general seizure, absent seizure, simple partial seizure, or atonic seizure? Simple partial, okay? So it usually starts on one side of the body and then progresses to both sides. The simple partial seizures, okay? And they're usually pretty aware of what's going on. They can't communicate with you, but they can kind of tell you after the fact what happened. Which diagnosis increases the risk of Ray's syndrome in conjunction with aspirin administration in the pediatric patient? Varicella, meningitis, strep throat, encephalitis. Chickenpox or varicella, okay? So we don't give kids aspirin and except for very, very special circumstances, okay? Because of the risk for Ray's syndrome. Encephalitis, what's encephalitis? Inflammation where?
Brain.
Yes, the lining of the brain. Yep. And meningitis is inflammation where?
Meninges.
Yes, meninges. Yep. Yep. So also the brain, but in the meninges of the brain. Okay. Good. Okay, what is considered a manifestation of retinoblastoma? Yellowish white reflex seen in the pupil, cloudy appearing cornea, increase in tear production, or red reflex seen behind the retina. So it's the yellowish white reflex seen in the pupil. So you're not going to see a red reflex in these kids. You're going to see instead like a yellow kind of white appearing lesion, which is actually the tumor that you're seeing in the retina. Okay. Okay, the presence of blood in the anterior chamber of the eye is called hyphema, encephalitis, varicella, or orbital cellulitis. Hyphema. Good. Remember, that's where you're going to see kind of that buildup of blood over the iris, between the iris and the cornea. Okay, another multi-select. Which signs and symptoms are characteristics of brain tumors in children? Projectile vomiting, seizure activity, decreased blood pressure, headache upon awakening. So everything except for decreased blood pressure, what do you think it would be instead? They have a tumor in their brain. Increased blood pressure, right? Yep. Yep. Good. I saw people doing this. Yep. A lot of them will start having seizure activities. This is also kids who have never had seizure disorders before. They start having seizures. And then another pretty dead giveaway is a headache as soon as you awaken. That's not improved by like Tylenol or ibuprofen at all. Okay. So if kids are saying like they're vomiting more often in the morning or they're having headaches right as soon as they wake up, that nothing's helpful, then I would be thinking about that kiddo having a brain tumor potentially, even without having seizures. Seizures kind of come a little bit later as the tumor, really grows. Okay. Multi-select. What will the nurse include when performing cranial or neurological assessments? Lung sounds, vital signs, motor activity, level of consciousness, a pupil assessment, or heart sounds. Yeah, so vital sounds, motor activity, levels of consciousness, and pupil assessments. Yeah. Not that you probably also won't be listening to lung sounds and heart sounds, but that's not necessarily a part of the cranial assessments. Okay, which is the most useful diagnostic procedure in diagnosing seizure disorders? Skull radiography, lumbar puncture, brain scan, or EEG, or electroencephalography. So EEG is actually the most informative and the most useful diagnostic procedure for seizure disorders. Okay. Not that they won't have a brain scan, they likely will have an MRI, but unless that kiddo's having a seizure while they are having the brain scan, then it's not going to tell you for sure. Okay. So the EEG is the most common or the most beneficial way to diagnose a seizure disorder. Okay, the 3-year-old or the mother of a 3-year-old tells she's concerned about her child's bow-legged appearance. Which is the best response? Do not worry about this. This is normal. Is your child having any pain or difficulty walking? Referral to a pediatric orthopedic physician is indicated immediately. I would be concerned if I were you. So yes, see if that child's having troubles with walking or pain. So if they're not having difficulty with walking or pain, bow-legged appearance at 3 can still be somewhat normal. Usually that should be resolved by like age 4. So they're getting very close to it being concerning. But of course, if they're having pain or they're having a hard time walking, then they need to see an orthopedic provider sooner versus kind of waiting and watching and seeing what happens. Okay, what is the most accurate diagnostic tool in diagnosing suspected osteomyelitis in the pediatric patient? X-ray, red blood cell count, bone scan, or serum albumin levels? Yes, bone scan. Okay. Okay. Intentional omission or a verbal or behavioral actions that are necessary for development of a healthy self-esteem is emotional neglect, physical neglect, emotional abuse, or physical abuse or emotional abuse. So intentionally omitting verbal or behavior. Yep, good job. That would be emotional neglect, which is a form of emotional abuse. Okay. So that is something that could be reported, especially if that's something that you guys are witnessing routinely. Okay. Multi-select. What are appropriate interventions when caring for a child in traction? Select all that apply. Use of a trapeze for positioning, liquid diet to prevent constipation, neurovascular checks performed regularly, other extremities must be immobilized, skin integrity monitored regularly, or upright for 30 minutes a day. Yes, use of a trapeze for positioning, that'll help kids kind of get to where they need to be in the bed and to, like, you know, assist you in positioning them. Neurovascular checks. If anybody's in traction, you're going to be doing those routinely. So if that's an option, that's something you're probably going to be doing. Okay. And then monitoring their skin integrity. Good. A 14-year-old was diagnosed with scoliosis with a 30-degree curve. What medical intervention is needed? Only exercise to increase muscle tone and posture, transcutaneous, electrical, muscle stimulation or a TENS unit, surgery with insertion of a Harrington rod, or use of a Milwaukee brace. Use of a Milwaukee brace. Okay. A 15-year-old has left leg amputated after osteosarcoma and reports severe left foot pain. What should the nurse do first? Remind him that he no longer has a left foot, provide emotional support, reposition for comfort, or medicate for pain as ordered. Medicate for pain as ordered. Yep. What do you think's happening there? Why is that kiddo having pain?
Phantom
Phantom pain?
Yep, phantom pain. Yep. So managing that pain is also important. Just as important as managing, you know, a real pain. So you'll also have to probably provide emotional support to that kiddo as well. Something that's common for like phantom limb pain is something like gabapentin or Neurontin.
I was just about to ask if there was a level of empathy associated with like the severed.
Yeah, I mean, you still would ask them their
the
pain scale. Yep, you would still ask them their pain scale. There's not a specific pain scale just for like amputees with phantom pain, but you still would ask for their level and all of that, just like you would with pain in any other form. Okay, last Kahoot question. What is the most important nursing intervention to identify and minimize compartment syndrome? Elevate the arm at least 30 minutes an hour. Treat pain with minimum amount needed to control it. Apply a blood pressure cuff above the cast or perform frequent neurovascular checks. Yes, frequent neurovascular checks. That's how you're going to be able to identify compartment syndrome, which is usually from crush injury fractures. Okay. And you're going to notice, you know, your pulses are going to change. They're not going to be as, you know, they're not going to be normal. They're not going to be 2+. There's going to be decreased sensation, pale color. They're not going to be able to feel you touching any longer. Those are all signs of potential compartment syndrome. Okay. All right. Good job with that. So I'm going to take a quick break. Let's take like a quick 10-minute break. Just because I have to run to the restroom and stuff, and then we'll start on the PowerPoint, okay? So start recording again. I'm going to share my screen. Okay. Okay. So like I said, neurological sensory. So that's chapter 23. And then chapter 24 is your musculoskeletal, okay? Here are your course objectives for 23. So make sure you know all these things when you're studying, be looking at them, okay? So anatomy and physiology of the ears. So it's controlled by the acoustic nerve, which is your 8th cranial nerve, okay? Your tympanic membrane at newborn stage is basically horizontal and more vascular. So you're not going to see a good light reflex. And the eustachian tube is shorter than that in adults. Okay, so they're going to be more, and it's also straighter. So they're going to be more likely to accumulate fluid back behind that tympanic membrane, which sets up the perfect storm for otitis media or ear infections. Okay. Eustachian tube function, so it should be ventilating, it should protect, and it should help with drainage. Okay. So common ear issues, obviously ear infections. So there's otitis external or externa, which is inflammation of the external canal. You can see that here. So most commonly, like when you hear swimmer's ear, right? Have you guys heard of swimmer's ear? They're talking about otitis externa or external otitis. So that external canal is inflamed. So a lot of times, if you touch on their tragus or their outside of their ear, if you push that in, they're going to have pain. And that's kind of how you figure out external otitis. Okay. Also, when you go to like pull their ear back to look in their ear, a lot of times that's painful to them as well. You want to make sure that there's not something that they've placed in their ear that's caused the external otitis. Or kids who have diabetes are more prone to getting external otitis. It's kind of more just inflammation in that ear canal. And then also if they have herpes zoster, so shingles, they can get a herpes zoster infection in their ear canal as well. So you want to look and make sure that there's no blisters or anything like that in the canal. You're going to treat with topical antibiotics, so drops, ear drops. Okay. They also make antiviral ear drops. Those can be utilized, but they're not commonly utilized. Usually what you see is some topical antibiotics. Sometimes they also have a little bit of steroid in them, so dexamethasone is commonly in them too, to help with some of the inflammation that you'll see a lot of times with the canal. Okay. And when you look past the canal, their TM is going to be normal. Okay, so no signs of infection in their tympanic membrane. Acute otitis media, so that's an infection back behind in the middle ear, back behind the tympanic membrane. So that's where you're going to see, really red. It might be kind of bulging like this with yellow fluid. Okay. So you're not going to see a good light reflex if they have an otitis media. It's a lot of times going to be bulging. If you use a pneumatic otoscope, which has like a little, almost like a blood pressure pump bulb attached to your otoscope, and you push that little puff of air in there, the TM isn't going to move like it should. So that's called reduced mobility as well. And then the purulent effusion is just like the pus color back behind that TM. Kids a lot of times are more prone to this if they've had, nasal congestion for quite a period of time, or, had a viral kind of upper respiratory cough. And kids are more prone to ear infections because of their eustachian tubes being straighter and shorter. That's why you don't see a bunch of adults getting ear infections too often. Okay. It's considered a chronic otitis media if it's lasting longer than 3 months. So if it's lasting longer than 3 months and not going away with different antibiotic treatments, then they need to see an ear, nose, and throat doctor for ear tubes, most likely. Okay. You're going to treat them with oral antibiotics, since it's not, if they don't have ear tubes, the topical drops can't get into where the infection is, so they need oral antibiotics. Typically that's started with amoxicillin, but there are others that you may need to use if it doesn't go away with the amoxicillin at first, or if that patient has an amoxicillin allergy. Pain-wise, Tylenol or ibuprofen, depending on their age. Remember, we can't use ibuprofen less than 6 months. So in infants, you have to be careful about that, okay? And then, like I said, if they continue to get ear infections, they have, it's lasting 3 months or longer, their hearing or things are affected, then they get laryngotomy tube placement, which is essentially they go into the tympanic membrane, do a little cut, drain that fluid out, and then put in a tube. So that way it can continue draining. Okay. If kiddos continue to have a lot of ear infections with the ear tubes in place, then they might have to get something like a button tube or a T-tube is the other one. So that's something that's more permanent. Your Mirengatobi tubes, they usually fall out within 1.5 years after surgery. But the T-tubes, those then stay in place. And eventually, as the child gets older, if they stop having the ear infections, then they will go in and take those T-tubes out and kind of patch where the tube was. Okay. Hearing impairment, so types of hearing loss. There's congenital hearing loss, which is hereditary. It's something that that child's born with. So usually from something in utero, so mom had an infection while she was pregnant that she didn't know about, or baby had low birth weight. Or, you know, when baby was born, they had a lot of resuscitation to get that baby stimulated to start breathing. Or, you know, they may have some abnormality in their ear development. So that's congenital hearing loss. That means baby's born with hearing loss, okay? Sensory neural hearing loss, that's going to come from the little cilia, the hair cells in the, with the cochlea and the acoustic nerve. So your 8th cranial nerve, okay? That there's going to be some damage there, okay? That can come from toxins. That can come from too much exposure to loud noises, or anomalies with genetics, okay? Conductive hearing loss, so that's going to occur when the tympanic membrane is blocking that sound from entering the middle ear. So earwax, chronic ear infections, or like a perforation of the TM. So a little hole in their tympanic membrane. All of those options can prevent conductive hearing loss. Okay. It's diagnosed by routine hearing screenings or a lack of response to stimuli. So if parents are like, you know, I holler for my kiddo multiple times a day and it seems like they just don't listen to me, some of that might be what we call selective hearing, right? They just don't want to listen to that parent in that moment. But if parents are continuing to have concerns about hearing and, you know, the kiddo's in preschool and they have delayed speech or something like that, it's better to just do a hearing check, okay? So that can be with an audiologist, or a lot of times you can do that in clinic. Kids with hearing loss might also start to have behavior problems, whether that be in school or at home. They get very frustrated that they can't hear enough and then respond to what's going on. So they start to have behaviors, okay? Treatments for hearing loss are cochlear implants, depending on if it's the cochlea that's damaged. So sensory neural hearing loss, you'll see the cochlear implants more likely, or hearing aids, okay? Or if it's conductive hearing loss, getting that earwax out of the way so they can hear, or getting that ear infection treated, okay? So your nursing interventions for kids who are hearing impaired, get at eye level with them, face to face, establish eye contact, talk in short sentences, and do not try to exaggerate your lips. Like, don't try to really enunciate with your lips or your face, because a lot of times that throws them off too while they're trying to read your lips. Okay, a nurse has been assigned to care for a 2-year-old boy who has been scheduled for a Mirengatobi with tube insertion. How should the nurse explain the surgical procedure and its indication to the parents of the child? And what instructions would the nurse provide to the parents before going home? You guys can just unmute and we'll talk through it. So parents are going to ask you, okay, my kid's having ear tubes. How do they do that?
You'll just explain the procedure, correct?
Yeah, so explain it to me.
I don't know. Hold on.
No, that's okay. So they go in and they cut a little opening and incision in the tympanic membrane. They drain that fluid out that's back behind the tympanic membrane in the middle ear. And then they put in a little tiny bead, almost it looks like it's a tube, in place of where that little incision is. And they leave the bead in place.
Okay, so what we'll tell them to like make sure they give them like they pain meds and stuff like that, watch for any signs of infection.
Yeah.
And if anything changes, take them to the emergency room.
Yep, or call the surgeon or something like that. Yep, exactly. Also eardrops. After they get tubes, they'll have eardrops for a period of time. Usually
I
like
have a question.
10 days. Uh-huh.
If the parent asks about procedure, don't we have to tell the surgeon to explain it to them?
Yeah, the surgeon should have explained it as well, but a lot of times surgeons don't explain it, the best. So parents will look to you as the nurse to then explain it again in a more simple way. But yes, if they have like significant questions or they're getting ready to sign consent forms or something, the surgeon needs to talk to them. You are absolutely correct.
Okay, thank you.
Okay, eye anatomy.
Were those the tubes that fall out on their own?
The myringotomy tubes, yes. Those fall out on their own.
Thank you.
Yep. And sometimes they fall out too soon, and then they have to have a repeat set. Or they get blocked or something, and then they have to go in there and do another set. Okay, so eye development begins at 4 weeks in utero. Okay. Newborn sight is very immature. They can't hardly see, past about a hand's length, about 6 inches in front of their face when they're first born. Okay. The shape of the eye is less spherical in the newborn, so that's why they can't see as far away. No tears until 1 to 3 months of age. So if parents call you and they're like, my 3-week-old is crying and crying and crying, but there's no tears and they're concerned about dehydration, what would you tell that parent?
That they're not developed.
Yeah, that it's a normal thing, right? That usually doesn't start happening until a month or even up to 3 months of age. Okay. Depth perception doesn't start to be something that is noticed or developed until about 9 months of age. So they're going to be, as they're crawling, they might be, or rolling places, they might be more at risk to kind of misjudge their depth perception and run into things. Okay. Jamie, for some reason, your camera's off. Okay, thank you. Okay, so visual impairment. So myopia is nearsightedness. So nearsightedness means they cannot see far away. It's kind of counterintuitive. It's kind of the opposite of what you would think. So myopia is nearsightedness, which means hard time seeing far away. Hyperopia is farsighted. So you can see good far away, but up close it's blurry. Okay. Strabismus is eyes crossed, okay? So both of your eyes cannot work together to focus on the same object. So there's different forms of strabismus, and it depends on the type of crossing of the eyes, okay? So estropia means that both the eyes drift inwards towards the nose. Extrophia is outwards. And this could be just one eye as well, okay? Hyperopia is usually one eye, or excuse me, hypoopia is usually one eye it can be straight, and then the other eye kind of drifts downward, or both eyes drift downward. And hyperopia is the opposite, so they're going to drift upward. Okay, and this is typically when they're trying to focus on an object with both of their eyes. You'll see the drifting of strabismus. Amblyopia, so that's the lazy eye, okay? And that can go inward typically, but it can also drift outward, okay? Or out and up, or in and up, or in and down. So like I said, what you're gonna see happen to strengthen those muscles, those extraocular muscles, is they're gonna patch their good eye for a period of time during the day, which is set by the ophthalmologist, okay? It's usually most of the day, okay? They may also get an opaque contact lens on that good eye, so it makes it difficult to see with that good eye, so then the other eye has to work harder. I feel like you see that a lot more in older kids who maybe didn't have the eye patch addressed when they were younger, okay? Either way, the goal of it is to make that bad eye work harder, okay? Strabismus, so this is cross-eyed. This is a type of amblyopia, like we talked about. So they cannot directly look with both eyes at an object, okay, because their muscles in their eyes aren't coordinated, okay? They usually are squinting, reaching for objects, and they miss the object. Or you'll see them cover their good eye or their bad eye to see. So that way they can focus on what they're trying to look at, okay? Headache, dizziness, tilting their head to be able to look a little bit better. You know what, I didn't talk about nystagmus. So nystagmus is abnormal eye movements. Okay, so it's an involuntary thing. A lot of times you have to worry about that there's something neurologically going on that's causing that. So a brain tumor can cause nystagmus to start happening, or other, pressure potentially on the neurologic system. So horizontal is when the eyes are darting back and forth horizontally. Vertical is vertical, okay? And then there's also rotary. So you'll see the eyes, the pupils of the eyes will actually kind of rotate. So those are the forms of nystagmus. Obviously, if it's a neurological condition causing that, treating that neurological condition should help the nystagmus resolve. But otherwise, if they wind up not finding a reason for the nystagmus, then these kiddos will have eyeglasses. Okay, dyslexia. So that's difficulty with reading. So it's a form of a reading disability where kids look at words and they flip the letters around in the words. It happens in the cortex of the brain as it's trying to process the symbols. So a lot of times kids with dyslexia, they need some remedial teaching. Okay, so tricking their brain into kind of focusing on those words. Eye strain, so this is caused from aching, burning, squinting. They're having a hard time seeing the board at school, so they're really straining their eyes. So usually these kids need to be sitting towards the front of the class and potentially getting their eyes checked and needing glasses. The other thing too, you have to get concerned about if kids are saying that they're having headaches, having their eyes checked, because eye strain can cause, headaches. Okay. Also, if kids start having attention span struggles and they hadn't had attention span struggles previously, that's usually another thing that should be recommended, is that they get their eyes checked or their hearing checked as well. Okay, conjunctivitis. So this is inflammation of the conjunctiva or the mucous membranes around the eyelid, okay? Caused by bacteria, viral, can also be caused in an allergic form, okay? So if it's concerned that there's bacterial, usually it's starts in one eye and spreads to the other. It's usually really goopy, purulent, yellow drainage. Soon as parents, or green, soon as parents wipe it away, it usually comes right back. And the sclera of the eye, so the white of the eye, is also usually irritated with pink eye. Pink eye is another term for conjunctivitis, okay? Now, some eye goop in a newborn and some redness of the lids, but no white or no injection or redness of the sclera of the white of the eyes, then that usually is from a blocked tear duct. So in that case, you just tell parents that that's a normal infant finding, and as long as it's gone by a year of age, then we don't get concerned about it. In teaching with conjunctivitis, you want to make sure you're teaching in with blocked lacrimal ducts or tear ducts. You're going to want to make sure you're teaching parents to wipe from the nose out, so they're not wiping that gunk into the eye further, okay? With a blocked tear duct, the other thing you're going to tell parents to do is like some light pressure right on the lacrimal, which is just right inside by your nose. Some light pressure with like a warm compress, and then wiping out. And they'll do that, you know, for a couple of minutes a few times a day. That'll help that duct to start working better. Okay. If kids are having tearing in both eyes and the gunk is there, you know, in the morning, but not all day, and maybe it's more watery drainage, in that case, you get more concerned about like a viral or allergic form of conjunctivitis. So you may not do the topical antibiotic eye drops in those cases. Okay. In babies, the ointments are probably easier for parents to get into their eyes. So like what you see, like the erythromycin ointment that newborns get, that's an ointment that you can use for conjunctivitis as well. Okay. Hyphema, so like I said, we talked about this kind of in the Kahoot. So this is a buildup of blood over the top of the iris, between the iris and the cornea. Okay. Most common from an injury, so like being poked in the eye. These kids will have to be on bed rest and have elevated head of beds at least 30 degrees, but no more than 45. Okay, because you don't want that interocular pressure and intracranial pressure to increase. Okay. A lot of times they'll do topical medications for pain and for concern of, you know, the injury. So they'll do antibiotics as preventatives as well. Okay. So retinoblastoma. So actually in this picture right here, so you're seeing the tumor right there. This is what you should see typically in kids when you're looking at their red eye reflex. And then this is what you see with kids who have retinoblastoma. It's also called a cat's eye reflex. Okay. So you're actually seeing the tumor right there. Leukorrhea is the other term for that tumor. Okay. So sometimes they'll have a loss of vision, they'll have strabismus, they'll have hyphema. And then in advanced tumors, you'll see that that eye on that side becomes more protruded, and that they'll have more pain on that side as well. Okay. Treatment options is removing the actual eye if there's no other ability to save vision on that side that's really progressed. chemotherapy to shrink that tumor. And then also laser therapy or cryotherapy will be used in some of those cases to kind of continue to, or radiation essentially, to continue to shrink that tumor down. And then photocoagulation, that's another form of potential treatment. So that is they're going in and they're destroying those blood vessels that are feeding that tumor. So hopefully the tumor doesn't continue to become enlarged. Okay. This is cancerous. Okay, so malignant tumor. Okay, the nervous system. So this includes your brain and your spinal cord. Okay. There's parasympathetic, there's sympathetic. They work in different ways. This chart is a really good one of like explaining the differences. Your fight or flight. Okay. Most neurological disabilities in kids are going to come from either congenital malformation, so from birth, or brain injury, or an infection. Okay. So monitoring the neurological status in children and infants. So changes in level of consciousness, headaches, pupillary changes. So their pupils were the same size and now one is a lot larger than the other. Changes in their vitals. Usually you'll see an increased blood pressure and a decreased pulse. You might also see changes in their respiratory pattern. So they might start having like agonal seesaw kind of breathing. Okay. In infants, your most common sign of increased intracranial pressure is what?
Bulging fontanelles.
Yes, some abnormalities with their fontanelles. Yep. So that fontanelle, you sit that baby up. You never want to check a fontanelle with that baby laying down because that's going to give you a false assessment. So sit that baby up and look at that fontanelle, feel it. If it's bulging, then you have to be concerned about increased intracranial pressure. Okay. If they start having nystagmus or having, eye drifts or things like that, then obviously that's concerning as well. Okay. Okay, so altered levels of consciousness. There's different causes of altered levels of consciousness. I won't read all of these to you. Probably most common, what you see in kids is potential poisoning, so drug overdoses, whether it was purposeful or an accident. Seizures, so post-ictal states after they've had a seizure, or increased intracranial pressure. Okay. So all of those can change the awareness to their environmental stimuli and causing them to have altered levels of consciousness. Okay, so cranial nerves, you guys should know these, know what they do and what they're tied with. So here's a good little mnemonic to try to remember them. So only one of the two athletes felt very good, victorious, and healthy. So each of those are kind of reminding you. Olfactory is nerve 1. Optic, which is your smell. Okay, olfactory, smell. Optic is sight. Ocular motor is the movement of the eye. Trochlear is rotation of the eyeball. Trigeminal is with your chewing and sensation on the face. Abducens is the eye movement like towards the center. So when you're doing your cardinal vision, the eye should move in all directions spontaneously. Okay. Facial nerve, so like wrinkling and closing your eyes, smiling, that's a way to assess your facial nerve. Vestibular, ocular, that's your hearing. Okay. Vagus nerve is your voice and your nerve function. Okay. Glossopharyngeal is taste and swallow. And then your spinal accessory is your head rotation, which is also known as just accessory. And then your hypoglossal is your tongue. Okay. And in your book, it talks about testing each of those as well. Okay, posturing. So posturing in different forms. So there's decorticate, which is flexor. So they're going to be really tense and flexed. So this is more of like a cervical spinal injury or cerebral hemisphere injury. Okay. And decerebrate is extensor. So this is when you see like, okay, football players, when they get knocked unconscious, a lot of times they're having the extensor reflex. So their hands will form up like E's. So extensor reflex, and that's when there's an issue with the midbrain or the pons of the brain. Okay. So it's just kind of telling you the different area of the brain that's likely affected. Okay. Orthotonos position, which is what this little toddler is doing. It's hyperextension of the neck and then arching of the spine. It's usually with a pathological cerebral disturbance. So there's something going on in their brain, whether it's a brain tumor or something like that, that needs to be addressed. Okay. Reye syndrome. So this is a non-inflammatory encephalopathy and hepatopathy. So there's going to be inflammation of the brain and also the liver. Okay. So you will see the risk of Reye syndrome increase if that kiddo has a viral illness or a viral influenza and they're given aspirin. Or what was the other one in the cahoots? Chickenpox, right? If they're given aspirin with chickenpox, that's a viral illness. So they're also more at risk for Reye syndrome. So you just avoid aspirin with kids unless they're a cardiac kid. Okay. Sometimes there's a genetic component that causes Reye syndrome to occur in one child versus another. Okay. These kids will also have vomiting and hypoglycemia if they're progressing towards Reye syndrome. Okay. So sepsis, so systemic sepsis, that's a response to infection with a bacteria. It's typically from viral or fungal infections. So you're going to get a systemic inflammatory response because of the sepsis. So all of your body systems are going to be involved in sepsis, especially if it's bacterial sepsis. Okay. So untreated can then lead to multiple organ dysfunction and then death if sepsis is not treated. Okay, remember we have to stay on until 11:35 since we took that break for full credit. Okay, meningitis. So if bacterial symptoms are a result from irritation from a purulent toxin, so a pus-like toxin, that's released by that bacteria. Usually you'll see petechiae, which are tiny little pinpoint burst capillaries, or like teeny tiny little bruising. And that's more suggestive of meningococcal infection, whether it's bacterial or viral meningitis. Okay. Remember, this is inflammation of the meninges. So inflammation of the brain is encephalomyelitis. Okay. When the spinal cord is also involved. So if the spinal cord is not involved, it's just encephalitis. But if the spinal cord is also involved in the infection and the inflammation, then it's encephalomyelitis. Okay. Kids with encephalitis or encephalomyelitis, you're going to see them have headaches, and then they're going to be really, really, really worn out and drowsy, like falling asleep mid-sentence. They eventually can progress to coma, so where they're not responding to things like, voices and things. They're maybe just have a pain stimulus response. Fever, cramping, belly pain, abnormal eye movements, those are all kind of later signs as well. Seizures in infants definitely can be a sign of, an inflammation in the brain tissue. Brain tumors, this is the second most common cancer in kids, okay, which sounds kind of crazy, but your sign for brain tumors are going to be very similar to signs of increased intracranial pressure. Okay. They may have decreased pulses or respirations, asymmetrical pupil response, that's a really big one, vomiting. Okay. The signs and symptoms vary based on where the tumor is located. Okay. Most common brain tumors are most commonly in the lower part of the brain. Okay. And you most commonly see the brain tumors in school-age kids. They are diagnosed by presentation and lab tests and head CTs or MRIs and EEGs. Okay. Chemotherapy and radiation. Some get both of those things. Some have surgery and then chemotherapy, or chemotherapy and then surgery. Okay. Seizures. So different classifications of seizures. Your generalized seizure is going to be that tonic-clonic grand mal seizures. Okay. They're going to get an aura. So they're going to have an abnormal kind of sensation. And then they're going to have the tonic-clonic seizures. So the tense and the relax, tense and relax. And then they're going to be postictal, which means they're going to be kind of confused, sleepy, out of it for a period of time. Absent seizures are also called petit mal seizures. So there's a temporary loss of awareness. So those are your staring spells, right? They're staring off and they're kind of out of it, and then they come right back to it. They don't have a postictal time period. Okay. Tics can also be a form of a seizure disorder. So a simple partial a lot of times is the tics. So like the frequent eye blinking happening, or mouth opening, or shoulder shrugs, those can all be partial, simple partial seizures. They remain conscious, but they might be kind of slightly out of it. Complex partial seizures, those are like unusual behaviors. So there was a kiddo that I saw that had complex partial seizures, and they had like behaviors like they would start running out of the room, eloping, things like that. Okay. Atonic seizures, those are your drop attacks. Okay. So seizures are diagnosed with EEG. A lot of times then they'll also do a CT and an MRI to see if there's any brain damage or abnormalities in the brain that's causing those seizures, like a tumor. Okay, lab tests can also potentially roll out electrolyte abnormalities that can cause seizures. Okay. The choice of the seizure medication depends on the types of seizures that those kids are having. Okay, so for febrile seizures, like I said, most of those kids will not have an anti-epileptic medication or an anticonvulsant medication given. Diet changes, there may be the need for kids to follow strict keto diets if the anticonvulsant medications are not managing their seizures. Okay. Okay. 3-year-old boy is a new patient with diagnosis of seizure disorder. What possible types of seizures might the child be experiencing? And how are they characterized? Let's start with that. So what are the options for seizures?
Absent seizures, general.
So let's start with what is an absent seizure? What are you going to see that kid do?
Stare out into space or blink.
Yeah, good. So they're going to kind of be staring off. And are they going to have a post-ictal state? So where they're totally like out of it? With
absent seizures?
With absent seizures? No.
No. Yeah.
Nope. Okay. So what's the next one?
The partial, what is it called? I'm sorry.
Well, there's simple partial and there's complex partial.
Simple
Yep.
partial. They would stay conscious, and it would be like maybe like you said, some of that blinking or shrugging of shoulders. But they would be conscious. Yeah.
Yep. And complex partial. Right, that was another one. That's where they have those weird kind of wonky behaviors. So they might like, I remember hearing a story one time of an adolescent who would like try taking her clothes off, which sounds crazy, right? That's totally not acceptable, but that was her type of seizure. So unusual behaviors.
Okay, unusual behaviors. Okay.
Yep. Okay, what else? General. What's the general seizure? What are you going to see with that?
The tonic-clonic.
Yep.
Or the grand mal.
Yep. Good. And then will they have a post-ictal state?
Yeah.
Yes. So they might have a urinary accident. They might have loss of bowel control after their seizure. And then, usually they're pretty sleepy and kind of not very responsive for a period of time.
How long does that period of time usually last? Like,
it depends on how the length of the seizure is and how significant the seizure was. Usually I would say about an hour or so, but with some kids, if it was a longer seizure, like a 20-minute seizure, before they got it stopped, then that's going to be more like 2 to 3 hours potentially.
Okay.
Or if they had a cluster of seizures, like so multiple seizures back to back, their post-ictal period of time is going to be longer as well. Okay, what aspects of the seizure activity should the nurse observe and document? So when a kiddo is having a seizure, what should you as a nurse be looking at and observing?
The time and the aura and what happens after.
Yes, the length of seizure. What about while they're actually having the seizure?
Just like their body movements and stuff.
Yeah.
Like seeing which parts, like their arms moving or stuff like that.
Yep. What about around them? Like if there's things around them.
Oh, remove them.
Oh, yeah, move it so they won't hurt themselves.
Yep. And then they used to talk about, putting a tongue blade in their mouth so that way they don't like bite their tongue off. We
Oh,
don't worry
don't do
about
that.
that anymore. Okay, that was kind of an old practice. Okay. And then what would you provide instruction-wise to those parents before they go home?
How to, I guess, safely deal with the seizure, like make sure that they are aware of how to keep their child stay safe and when to call for like the paramedics or something to come so that it won't get worse.
Yep.
And take medications as prescribed.
Yep. Yep. Seizure medications are really, they have to be like almost to the minute given on time. So those are very, very strict with timing compared to other medications. Okay. They may also have a rescue medication. So if their seizure's lasting longer than 3 minutes or 5 minutes or 10 minutes, depending on their guidelines, the parents may need to give that medication. A lot of times it's rectal, but now they're getting to where they have intranasal medications that they can inject, parents can inject up their nose.
And so to like stay calm and like not be shouting or like, you know, to be not adding alarm to the situation for them.
Yeah. Yep. And parents should also be timing the length of the seizure, right? Just like you will be as a nurse, and making sure that their surroundings are safe. Also letting the school know about seizure disorders, even if they are like absent seizures. Because, you know, if teachers are seeing more absent episodes, then, you know, maybe that kiddo's getting to the point where they're going to need a medication to help with their absent seizures. Okay. Any other questions about seizures? No. Okay. So head injuries. Head injuries are the #1 cause of death in kids less than a year of age. Unfortunately, a lot of that is from head trauma related to abuse. Okay. But think about it. Kids are also like climbing on things and walking and all of that at that time. So, and their heads are still heavier than most of their body because they're bigger. Okay. Concussion is a temporary disturbance in the brain, and then it usually is followed by a period of unconsciousness. So even if it's 15 seconds, 30 seconds. Okay. A child's response to a head injury may be different than an adult. They might kind of be more irritable, more tired, more fussy. Whereas an adult, you know, they might have the classic vomiting kind of symptoms after a head injury. The child's lack of ability to communicate and cooperate make it hard for you as nurses to assess their neurological status. Okay. But knowing kind of the normal growth and development patterns of those kiddos and they're based off their age is going to be what's helpful to you in evaluating their status. Also asking the parents, like, okay, is your kiddo usually able to, you know, walk without an issue? Are they usually walking on their tiptoes? You know, things like that can really be helpful in talking with the parents about their child's normals when there's a concern for a head injury. Okay. Shaking baby syndrome. So this is what you see with child abuse. Okay. So they're going to have subarachnoid, subdural, retinal hemorrhages. They can also have cervical spinal injuries as well. Okay. They're going to have permanent injury or death to the brain in these kids. So these kids are not going to be able to regain what they had prior for function. Okay. Headaches, usually fussiness in infants and toddlers is what you're going to see. They're going to be more worn out. They're not going to be eating as well. They're not going to be acting like their usual self. Blurred vision if they're older kiddo, vomiting, dyspnea. And, you know, obviously in severe cases, the kid's going to be totally unconscious. A lot of times it's determined with like CT scans or an MRI that they have multiple brain bleeds. And then, you find out that they also have fractures and things like that too. Okay. Okay, we'll do this last thing and then you guys can hop off. 7-month-old girl is brought to the emergency department by her mother's boyfriend who is babysitting for her. The baby is in an irritable state. The nurse overhears the physician say that he suspects shaken baby syndrome. What might cause the physician to state that suspicion? And what signs should the nurse look for that could indicate that they've sustained a head injury? So what are some things that might lead that provider to be concerned about shaking babies?
The irritability.
The irritable state that the
Yeah.
baby is in.
Yeah, the baby being like unconsolable and stuff.
Yeah.
And the age limit.
Bleeds, right?
Vomiting.
So what was that, Jamie? Sorry, I couldn't hear you.
Vomiting.
Yeah, vomiting.
Vomiting.
Yep. Retinal bleeds. So like with retinal bleeds in the eye, when you look at the eye, a lot of times you can see them. Okay. Yeah, what else might be a suspicion? What if they do like an X-ray?
Maybe stress fractures or fractures in the neck.
Yeah, you might see fractures. Yep.
Mhm.
Or multiple stages of healing of fractures. That's another sign of abuse. Okay. So fussiness, vomiting. What else would be another sign of head injury in an infant, specifically 7-month-old?
If they start having like seizures or something.
Seizures,
Or what about
The
no, I don't think
drowsiness.
that was it.
drowsy.
Vomit. Oh, yeah.
What about their fontanelle?
Oh, bulging.
Yeah, there we go. Infants, fontanelles. Okay.
Yeah.
Those are good, helpful clues to us as nurses. Okay. So if you have an infant and you're suspecting head trauma because they're really irritable, sit that baby up and look at their fontanelle and palpate it. Okay. Good. All right. Any questions? No? Okay, so right after this at noon, I'm going to start my exam review if you guys want to join. And then if you guys want to go over your exams, like I said, please send me a message letting me know